Okay, good day everyone. So welcome to the second week and the second session of our epidemiology lectures. So last session we built the foundation of learning how to count the disease, incidence rates, prevalence, attack rates, mortality rates, and case fatality rates. If you recall the dengue example from the Manila hospital, we were essentially asking how many cases are there and how fast that is the disease spreading. So now we shift our question. No, instead of just counting, we are going to ask: is there a relationship between an exposure and the disease? And when a hospital wants to screen a population or a particular group of individuals, we will ask, how good is this test at finding the disease? So by the end of this session, you'll able to not just compute, but interpret risk ratio, odds ratio, attributable risk, sensitivity, specificity, positive and negative predictive values. The tools that you need to determine, no, depending on your study design and clinical context. So the learning outcomes for this would be, yeah, compute the risk ratio and odds ratio and interpret it based on a 2 by 2 contingency table. So these are two main measures of association of epidemiology. Second, we will learn when to use the risk ratio and odds ratio based on the study design. They measure similar things, but are appropriate for different study designs. Third is computing for the attributable risk, the AR% in the population attributable risk. These tell us not just whether an association exists, but how much of the disease burden we could prevent by removing that particular exposure. Fourth, we will define and apply sensitivity, specificity, positive predictive values, and negative predictive values, and apply them to screening scenarios. So this would be very practical if, especially when we're talking about screening and diagnostics. And finally, we will explain how disease prevalence affects the positive and negative predictive values. And this is the concept that most students find very difficult. But hopefully I can make it explain it in a more practical sense that you can use it in the clinical settings. So everything we do today would be derived from one simple table. So this is the 2 by 2 contingency table. So on the columns, we have the disease status. So whether the disease is present or not. On the rows, the exposure status. So whether that individual is exposed to that particular factor or not exposed to that particular factor. So that leads us with four different cells. So A are those exposed to the factor and have the disease. So in a way, they are the true positives. And then those who are exposed but doesn't have the disease would be controls that are exposed. This one, the third one, is those who have the disease but were not exposed to that particular factor. So in screening, this is the false negative. And then the true negative, which the last one is those without the disease and those not exposed to that particular factor. So if you would see, yeah, the cases who are exposed, non-cases who were exposed, cases who were not exposed, and non-cases who were not exposed. So from there, we can compute the relative risk, the odds ratio, sensitivity, specificity, positive predictive value, and negative predictive value. And we will have some examples later. So let's start with the risk ratio or the relative risk. So it is the most intuitive measure of association, and it answers the question, how many times more likely are exposed people that will develop the disease compared to those that are not exposed. So the formula is divides the risk in the exposed group by the risk in the unexposed group. So the risk in each group is simply getting the number who got the disease divided by the total number in that group. So if you would go back dun sa ano natin, 2 by 2 contingency table, it is A, so the proportion of with the disease that are exposed compared to the sum of all that were exposed divided by the false, those who are with the disease but not exposed, divided by those all individuals that are not exposed. So ito yon. So the risk of unexposed. So you would get a value, it's either less than decimal value or less than 1, exact 1, or more than 1. So if it's equal to 1, there's no association between the exposure and the disease. If it is less than 1, the exposure decreases the risk and therefore it's protective. But if the relative risk is greater than 1, the exposure increases the risk of developing that disease. Therefore, it can be classified as a risk factor. So let's look into an example here. Yan, yung very old British doctors cohort study. So this was authored by Dahl and Bradford Hill that followed up 34,440 male British physicians for 10 years. So definitely there are smokers among physicians even during that time. Among heavy smokers, those smoking 25 or more cigarettes per day, the death rate from lung cancer was 166 per 100,000 per year. Among non-smokers, it's relatively smaller, 7 per 100,000. So simply, you would divide the risk of the exposed, which is 166, versus the unexposed, which is 7, and you get 23.7. So that means, and if you would round it up to 24, heavy smokers had nearly 24 times the risk of dying from lung cancer compared to non-smokers. And this has become one of the most influential calculations in medical history. The causation or the risk of smoking in the development of lung cancer. So you use relative risk when you calculate the risk in each group. That is, when you know how many people are at risk and how many develop the disease. This is possible in cohort studies, cross-sectional studies, and randomized controlled trials. It is not directly calculable from case control studies because in those studies, you do not start with a defined population at risk. The odds ratio, meanwhile, or OR, is the measure of association used in case control studies. So instead of comparing the risk, it compares the odds, the probability of an event, or the chance that it might happen. So it is the probability of those, yeah, the probability of those exposed as compared to the the probability of those who are not exposed and have the disease. So in case control, if you would go back, you start with people who already have the disease or the cases and those who are doesn't have the disease or the controls. And you look back to see how many in each group were exposed. Because you have sampled cases and controlled separately, you cannot calculate incidence in the exposed and unexposed groups. So you cannot compute a risk ratio, but you can compute the ratio of the odds of exposure among cases relative to the odds of exposure among those without this disease or the controls. So ito yung formula na yon. If we would use the 2 by 2 contingency table. So interpreting it, yung OR, if it is equal to 1, there's no association. Again, if it's greater than 1, it means there are higher odds among cases. If it is less than 1, it means there are lower odds among the cases. So it's slightly different in terms of its interpretation. However, you should we should take note here, and there's an important principle called the rare disease assumption. So if the disease is rare in the population, for example, if it is less than 10%, the odds ratio is numerically very close to the relative risk or the risk ratio. So in those situations, we often say the OR approximates the RR. This is why you will see OR used and interpreted as if it were an relative risk in many cancer studies, when the disease is rare enough that this assumption holds. So let's look into for an example here of getting the odds ratio. So this time, they look into the link of Helicobacter pylori infection with gastric cancer. So this is a systematic review in 2001. And as you can see here, they made a 2 by 2 contingency table here. So those again, yeah, no, so the columns would be those with cancer or without cancer, and then the rows would represent whether that individual has an exposure to H. pylori or none. And these are the individuals, no, based on that particular grouping. If you would compute the odds ratio again, so A times D, so 1228 times 3,966 divided by B 2,302 times 510 C. So the quotient is 4.15. So that means those individuals infected with the Helicobacter pylori had 4.15 times the odds of developing gastric cancer compared to those not infected. So since gastric cancer at that time was relatively rare, this odds ratio closely approximates the risk ratio. And this finding led eventually to global guidelines recommending the eradication of H. pylori as part of a primary prevention strategy for gastric cancer. And this is primarily used also in situations for peptic ulcer disease. If the patient also has Helicobacter pylori infection based on testing. So again, when to use risk ratio and odds ratio? Risk ratio is used for cohort, cross-sectional, randomized controlled trials. Um, when the population at risk is clearly defined and when disease incidence can also be determined. If odds ratio, it is for case control studies, logistic regression analysis, and when you can sample separately the cases and the controls. You cannot do that in the studies on the risk ratio. You can also use odds ratio in rare disease scenarios and also in meta-analysis and systematic reviews. So those are things that can measure the association between an exposure and a disease. But the next question for whether you're in the public health or a hospital administration is how much of this disease is actually caused by the exposure? What's the magnitude? If we eliminate the exposure, how much disease could we prevent? And these are the questions that the attributable risk measures. So we have three related measures on this side. We would be using the interheart study for this example. Has a cohort of 10,000 smokers and 350 developed myocardial infarction. And then in the cohort of 10,000 non-smokers, 80, so much lower, developed myocardial infarction. So in the overall population, where 50% are smokers, there are 215 myocardial infarction cases per 10,000 population. So let's compute for the attributable risk. So attributable risk, also called the risk difference, ask how much additional risk do smokers carry compared to non-smokers, purely because they're smoking and not considering other factors. So you calculate first the risk among the smokers. So 350 had MI divided by 10,000 smokers. And then you compute also the non-smokers. So 80 MI cases among 10,000 non-smokers. And that is 0.008 or 0.8%. And then you subtract them both and you come up with 0.027 or 27 extra cases of myocardial infarction per 10,000 individuals. So the implication here is if we could remove smoking from those who are actively smoking, or cigarette or tobacco, using tobacco or even vape, we would expect 27 fewer cases of myocardial infarction per 100 per 10,000 population. So that is attributable risk. Now there's also attributable risk percent. So it is slightly different uh, in such it answers the question what fraction is actually caused by their smoking. So this helps us prioritize and tells us how much of the disease in the exposed group we could eliminate. So again, we would compute now for the risk ratio. So the risk of those exposed as compared to unexposed. So again, yun yung 0.035 divided by 0.008. And we got the RR of 0.375. And then the formula is yung RR minus 1 divided by RR times 100. So here, based on this formula, the answer is 77.1% because you multiplied it also by 100. So the interpretation here is that 77% of myocardial infarction in smokers is attributable to smoking, which is relatively high. And quitting could prevent 77 of every 100 myocardial infarctions in the smoking group. So this is a very compelling public health argument for smoking cessation programs, not just in hospitals, but also in the community setting. And then finally is the population attributable risk percent. So it now expands the question now to the entire population, not just those who are exposed. So the question that it answers is if we eliminated smoking from the entire population, what fraction of all MI cases could we prevent? So these are the steps. So the first one is what is the risk in overall population? So again, yung ano is in based on the data that's given, it's 215 per 10,000. So that's 0.0215. And then the next is what is the risk of those unexposed? So unexposed, the non-smokers, 80 divided by 10,000. So it's 0.008. And then you would subtract the two risk ratios. So 0.0215 minus 0.008 is equal to 0.0135. And then you divide it by the risk ratio of the exposed group. So 0.0215. And then you will get the answer of 62.8%. So that means if smoking would be eliminated from this population, about 63% of all myocardial cases in the population could have been prevented. Again, this is a very compelling case that would make you consider smoking cessation programs. Before we move into the screening measures, I want to just delve into a very important aspect also in epidemiologic data. So variables are very important. So these are things that you measure and you are working it in which you determine which statistical test you will use, what measure of association would be the appropriate one, and how would you summarize and present your data. So there are primarily two types, no? The quantitative variable, the numerical, or the qualitative or categorical variables. So yung quantitative has two, the continuous and the discrete. So continuous variables can take any value in a range. So it's infinitely divisible. There's no natural gaps that's found between the values. So these are some of the examples: blood pressure, uh, body temperature, the serum glucose. So yung laboratory test wherein they would give you a definitive numerical value, and then other physical measurements such as height, weight, BMI, and age. Discrete variables, meanwhile, are count data. So you can only take whole number values. Unlike in so continuous, there are fractions or decimal points that can be considered. Like for example, you cannot have 1.5 hospital admissions, or you cannot say there are 16.75 deaths in a particular institution because it should always be a whole number. They are analyzed differently from continuous data. So there are situations the variables should be of discrete in nature. Now, how about qualitative? So it places observations into categories. So there are two main types also, the nominal and the ordinal variables. The nominal variables have categories with no natural order. So, for example, yung blood type, you cannot rank here which is the best or the more severe or the most severe among the four. But you can assign that particular individual based on the blood type. And then others would be, yung presence of diseases, diabetes, hypertension, tuberculosis, or none. And then yung gender, no? Male or female. Ordinal variables, meanwhile, has a natural order. And then the intervals here are not necessarily equal. So, for example, pain scale. Pain scale is numerically from 1 to 10. So it has an order that 10 signifies the most severe pain that the individual experiencing as compared to 1, which is very minimal pain experience. But we cannot assume, no, that the difference, for example, between the pain score of 3 and 5 is similar to the difference between the pain score of 7 and 9. So another example of an ordinal qualitative variable would be yung cancer staging. No? So stage 1, 2, 3, 4. The New York Heart Association classification of heart failure. And then yung mga socio-economic status as well. So now let's go to yung diagnostics and screening tests. So this is a important aspect we need to evaluate the diagnostic and screening test if you're an hospital administrator, because you will be asked to decide whether you have to adopt that particular laboratory test or other diagnostic tools for various diseases, whether it's tuberculosis, hypertension, or even malignancy. So you need to understand determining these values here. So let's say our scenario here, no? So a new rapid tuberculosis antigen is being evaluated on 1,000 patients in a hospital in Manila. So 200 patients was confirmed with tuberculosis using a gold standard. So it's very important here, no, for the um in if you're analyzing the diagnostic tool, there should be a gold standard in which you're basing the detection of the presence of the disease versus the ability of that particular screening test to detect also that disease. So as we can see here, so using that new rapid antigen test versus the gold standard. So ito yung gold standard, ano, the TB negative, positive and TB negative. So here are the values. So dito 170. What does this mean? So 170 individuals who were diagnosed with or with confirmed TB using the gold standard also had a positive test uh, detected based on the rapid antigen test. Meanwhile, this one, they tested positive for the rapid TB antigen test, but TB is not detected on that on the gold standard. This slot, meanwhile, is those who were detected with TB using the gold standard, but it wasn't replicated in the diagnostic tool of interest. And finally, those who were had negative results using the gold standard and also have a negative result in of the screening tool of focus or of interest. So you built your 2 by 2 table. Next, you would compute sensitivity. So it is the true positives divided by the true positive plus the false negative. So if you would and then multiply it by 1,000 because this is expressed in percentage. So if you would see here, 170 divided by 200, so that's 85%. So the interpretation is the test correctly identifies 85% of true TB cases. 15% are missed. So that's the problem because they go home and untreated. But ideally, you want to have a much higher sensitivity so that it detects a significantly high number of individuals having that disease. Specificity, meanwhile, you have to take into consideration the true negatives, meaning those without the disease, divided by the sum of those negative with the gold standard, but eventually had a positive result based on the screening test of interest. So 720 divided by 800, it's 90%. So this means the test correctly identifies 90% of true non-tuberculosis cases or those who are negative for tuberculosis. And then 10% are false positives. So the problem here is that they receive unnecessary treatment because they're negative, but because the screening tool detected it positively, and that would be challenging and it could be difficult because there are multiple adverse reactions that could happen and it's impractical. And the more difficult part would be there might be the development of antibiotic resistance because of the use of those drugs in such setting. So a concept that I would also discuss here would be the sensitivity specificity trade-off. So here is a fundamental insight of evaluating diagnostic tests. You cannot maximize both specificity and sensitivity with a single cut point. So if you lower the diagnostic threshold in such you want to catch more true cases, you will also catch more false positives. So therefore, you increase the sensitivity but lower down the specificity. Now, if you raise the threshold to reduce the false positives, there's now the tendency to miss more true cases. So the clinical context here dictates which you prioritize. So like in this case, wherein TB screening is of the focal point, where missing a case means ongoing community transmission, you would want a high sensitivity at the initial screen. Then, for patients who test positive on the screen, you confirm it with a high specificity test, like, for example, sputum culture, before committing to treatment. So, there is what you call a sequential testing, and it is a standard practice in public health. Other metrics that you would measure also for screening and diagnostic tests would be the predictive values. If we would go back about sensitivity and specificity, it answers the test questions that how good is the diagnostic tool finding cases and how good is the diagnostic tool ruling them out. But you as a clinician or maybe a staff in the hospital ask a different question. The question now is if the patient tests positive, what is the probability that they would have the disease? And vice versa, if you have the negative result or negative test, what is the probability that you really don't have the disease? So there now this where the positive predictive value and negative predictive value comes in. So you can compute yung positive predictive value and negative predictive value. So going back here, so yung positive predictive value is, again, all the positives dun sa test, ilan yung meron talaga ng disease. So A divided by the sum of A and B. Meanwhile, yung negative predictive value is how much of those who are negative on the test really does not have the disease. So it's the sum, it's the ratio of D, the true negative, divided by the sum of the false negatives and the true negatives. And you can get these values. So how prevalence affects the positive predictive value and negative predictive value. So let's look at a same test, but it is performed in a different populations. So, for example, in a area with a low prevalence, uh, general HIV screening, for example, was performed, and based on the findings, there's 9% positive predictive value and 100% negative predictive value. So it has a good negative predictive value because you're sure that the negative test means that the patient doesn't have HIV. But the problem here lies within the positive predictive value because of its relatively low number, 9%. So that means 9 of 100 positives are false. And that is relatively high because as we all know, the HIV stigma is very difficult. And if you would convey that result to 9 individuals per 100 uh, persons, that could have a significant impact on the psyche of the patient. And also, you need to do further testing, which is more expensive. Or another option could be you would go into treatment that might be unnecessary. Now, let's go now. What if the setting is of a moderate prevalence? 1%. So, for example, is yan, yung sexually transmitted infection clinic. So, positive predictive value is 50%. And then again, good negative predictive value. So, yung positive predictive value, while better, medyo mahina pa rin siya. Meaning, those who are positive, 1 out of 2 or 5 out of 10 individuals lang are true cases. So that is that could still be very difficult now for hospital administrators to decide on things. So that would now be the judgment call of the hospital administrator on based on this, will we still do those particular screening tests for HIV. Now, this would not take intuition and clinical experience from the hospital administrator. Now, for example, the area is of high prevalence. So like those with known high-risk group HIV. So the positive predictive value now is very high, 91.7, and still a very good negative predictive value of 99%. So, therefore, if it is positive, most of them are, are true positives. Therefore, you can do confirmation tests and eventually treat those individuals. And then finally, in the setting of very high prevalence, for example, those in active TB ward, look at the positive predictive value is very high at 99, and so goes the negative predictive value. So you have a very high confidence in both results. So now let's look at an example of screening. Pap smear for cervical cancer screening versus the human papilloma virus testing. Yeah, HPV is found out to be a risk factor in that leads to cervical cancers. That's why HPV vaccines are already given to usually women of reproductive age to minimize the risk of developing cervical cancers. But let's go back here. This is an old study in 2007, um, wherein they screened 10,154 women with both pap smear and the HPV DNA test. So the development of a high-grade lesion was used as the disease endpoint because these are the high-grade lesions that would require management or treatment. So what are the results? So the pap smear detected 55.4% of true CIN2 positive cases. The HPV test is higher at 94.6. So therefore, this test significantly misses far fewer cases. Now, how about specificity? The pap smear, 96.8, relatively good. And the HPV DNA test, relatively also good, but lower. The pap smear has fewer false positives. because of relatively higher specificity. Positive predictive value, meanwhile, is very low for both the pap smear and the HPV DNA testing. So this reflects the low prevalence of the high-grade lesions even in a screening population. And then finally, the negative predictive value is also high in pap smear and HPV DNA testing. So this is very reassuring, which means that if you have negative results using either pap smear or the HPV DNA testing, you're 99%, more than 99% sure that you don't have that disease. So, what was the recommendation based on this study? So, for high-risk women age 30 and above and for resource adequate settings, so the World Health Organization recommends now the HPV based testing as a primary screening tool. But that is um, for primary screening in certain areas. Still, for low prevalence populations or follow-up after treatment, the pap smear's high specificity reduces the burden of unnecessary colposcopy referrals. Because you need to do colposcopy in the HPV DNA testing, which would be a relatively invasive procedure versus a mere pap smear. Now let's look into an example. I'll just okay. Oh, I need to use me. Need to okay. Yeah. Okay. So let's say for example again dun sa hospital, no? So you made a case control study. Yeah, you have 200 stroke patients and 200 individuals without stroke. So in among those cases and controls, 140 of those with stroke have hypertension. Those without stroke, it only out of 200, it only had 80 individuals. So separately, the hospital screens 10,000 high-risk adults using a blood pressure device. And then the prevalence of hypertension is, let's assume it's 30%. So what you will do, so first, compute the odds ratio because it's a case control study. So again, A times D divided by B times C. So the answer is 3.5. Meaning, hypertensive have 3.5, 3.5 times the odds of getting stroke versus those who have normal blood pressure in this hospital group or sample. Now, yung sa screening calculations naman, again, this is determining the sensitivity, specificity, positive and negative predictive values. So, these are the values. So, the contingency data. And if you would compute, so again, yung positive predictive value would be those the ratio of true positive over the sum of the true positives and the false positives. Kaya ito yun. And the result is 82%. Yung negative, meanwhile, is the ratio of those who are true negative compared to those who are detected negative based on the diagnostic tool. And the result is a relatively good negative predictive value. And then the last one would be, yeah, yung positive predictive value, negative predictive value, and the false positive rate. So sa PPB, 82% of those who screen positive, meaning 82% truly have hypertension. So this just goes to show that it justifies yung follow-up confirmatory testing and early intervention of blood pressure among individuals to avoid the development of stroke. So the key takeaways here is that the relative risk or the risk ratio compares risk directly, and you use it in cohort studies. The odds ratio compare the odds, and you use it in case control studies. When the disease is rare, um, odds ratio and the risk ratio is almost the same. Attributable risk measures the excess disease caused by an exposure. So yung the attributable risk percentage guides population level prevention priorities such as smoking cessation and obesity control. The sensitivity and specificity are fixed properties of the test. Higher sensitivity means fewer false negatives, and higher specificity means fewer false positives. Positive predictive value and negative predictive value are not fixed, and they depend on population prevalence. The same test has a very different positive predictive value in a low prevalence against a high prevalence population. And finally, when you design a screening program, you match the test choice to this to determine yung disease prevalence and the clinical consequences of the false positive and false negative results. So with that, thank you for listening, and I would be answering questions later.